welcome to UofL Today with Mark Hebert on Cards Radio 790 WKRD. So glad you're joining us for the show that's about all the things going on at the University of Louisville, including some great research, which we're going to be talking about here for the next half hour or so. On the show today, we'll hear from a UofL political science professor who has insight into President Trump's America First policy and what our allies are saying about it, because he's talked to a number of our allies. Also, we'll talk to a child neurologist about movement disorders like tics and tremors in kids, as well as the latest on treatments for cerebral palsy. But first, you probably know an adult who suffers from migraines, but did you know that migraines are one of the most common neurological diseases in children? Dr. Michael Sowell is a neurology professor in the UofL School of Medicine. He has more on migraines in kids. Dr. Sowell, good to see you.
Good morning. How are you?
I'm all right. I had no idea. My kids never got migraines. I don't know that I know anybody who has kids that get migraines, but you're telling me that it's pretty frequent for kids to have migraines, right?
So it's common. So about 12% of the population has migraine, and about half of the individuals who have migraine have onset before the age of 20. So it's very common in the general population.
And we're talking kids at what age will they start getting migraines?
Well, they can have them as young as when they begin to talk.
Really?
Yes. But they become closer to the approximate prevalence in the adolescent age. So
12, 13, 14,
12, 13,
that's when
14.
you start.
Yeah, so the most common in our headache program is 12 to 17, but we see all ages, of course.
And so how do they figure this out? Did they just, the kid comes home from school, a couple days in a row with really bad headaches, and they tell mom and dad that's how you figure it out?
So migraine is a specific headache disorder where headache is one of the features, but the nausea, vomiting, light, and sound sensitivity, and typically children want to lay down and go to sleep when they have a migraine. So there are certain diagnostic criteria, and you look for, migraine is a primary headache disorder, so you also look for other things that might cause headaches as well as part of the investigation.
Okay. Again, we're talking with Dr. Michael Sowell from the University of Louisville. We're talking about migraines in kids, and there were recently some new guidelines that got approved by some federal agency or some association about migraines in kids. What were those?
So the American Academy of Neurology, which is the largest body of neurologists actually in the world, publishes practice parameters where they assemble a group of pediatric headache specialists, and we recently published a revision of the parameters for acute and preventive treatment of migraine in children, and that just came out in the last few months. So
what's new?
So
what's old, what's new?
These are revised parameters from 2004, so this has been 15 years basically since the parameters were put out, but this outlines and delineates the options for both acute and preventive treatment of migraine in children, and some of the newer medicines that have been approved and those that have additional scientific evidence of their safety and effectiveness.
Okay, and so there's new drugs out there, or what's the gist of it for parents who are trying to figure out, and for doctors who are trying to figure out what's going on with their kids when they're migraines?
So there's new medication options for migraine. The most commonly prescribed medication class are called triptans. Triptans are medications that are not narcotic or painkiller type medications, but they're specific to the mechanism of migraine. And there has been additional scientific evidence both generated and published since 2004. So these are an update on which medications are both safe and effective for this age group.
So that's how it impacts the care, is these new, I'm going to call them drugs. I guess they are drugs, right? They're not natural.
Drugs, medications, sure.
Okay. And when you're looking at this from a holistic standpoint, is there anything that either parents or doctors should be looking at, perhaps in part of the new guidelines, other than drugs, diet, yes, or is there anything else that we're talking about here?
So there are lifestyle factors and or psychological factors that affect or impact migraine, and so that's part of the guidelines as well, is that physicians and other providers should be addressing these issues and then making those lifestyle changes or recommending those lifestyle changes for children and adolescents with migraine.
Okay, we're talking with Dr. Michael Sowell, a neurology professor in the UofL School of Medicine. We're talking about kids with migraines and some new guidelines on how they should be treated. For parents, what do you tell them? I mean, how does a parent have any idea? You mentioned that their kid is suffering from migraines. You mentioned that it's stuff other than headaches, but parents are sometimes, brush it off, it's no big deal. Or they go the flip side and it's, oh my God, they got a brain tumor or something, So how do you deal with those parents?
Right. So the initial approach is to distinguish primary and secondary headache disorders. So primary headache disorder is migraine, which is based upon clinical criteria. And so obtaining a thorough history and physical is important. And then sometimes supplemented with imaging studies of the brain to make sure there's not a tumor or other problem with the brain that might create headaches. But then proactive discussions on approach to acute treatment, which is taking a medicine when you have a headache, and then preventive treatment, which is taking medication to reduce frequency, severity, or duration of the headaches. But then also addressment of lifestyle management issues. And so we're blessed to have a pediatric psychologist, for example, Dr. Throkeld, in our pediatric headache program, who is helpful with addressing those issues, and then other stresses and kind of positive coping strategies in dealing with.
So there's stuff other than medication that can be done, that are strategies. Are physicians, family physicians, pretty good about diagnosing a kid with migraines, or are they at least pretty good about passing them along to a neurologist or a psychologist, those kind of things?
I think they're both. So the the first lines are the family practice doctors and or pediatricians who are seeing children with headache disorders, and we teach them as they come through pediatric neurology at UofL about diagnosis and management, and I think they're pretty good at looking for dangerous secondary causes for headache and things like that, and then appropriate addressment with kind of first line treatment. We do tend to see more refractory children, sort of refractory to the first line treatments at UofL in pediatric neurology.
Dr. Michael Sowell is a neurology professor in the UofL School of Medicine. That's who we're talking to right now. So what does UofL have? What treatments for migraines can a parent and their kid find at the University of Louisville?
So we have the, of course, basic diagnostic assessment, so history and physical exam, and medications that are approved for treatment, both acute and preventive treatment. But then we also have a specialist in pediatric acupuncture, Dr. Elizabeth Dahl, in our group.
Oh, yeah, I've talked to her before.
And then, as I mentioned, pediatric psychology sees a lot of our patients, and then we coordinate services with other disciplines as well. So
you got a little group that kind of deals just with this problem in children. And are there any research projects going on that either you've got going or somebody else in your group has going on migraines in kids?
Well, we have several. We have our main one that I can discuss is we have just a database where we can collect data that is then shared at multiple centers, so de-identified data, to then kind of improve upon the treatment of migraine in this age group, and draw comparisons with other centers as to what they're doing.
Final note: advice to parents. Your kid comes home with a couple headaches, or if they're throwing up during the week. What should they do?
I think take it seriously and take them to the doctor. There are treatments that can be offered if not getting the kind of appropriate management within the primary care. Then certainly pediatric neurology is available at University of Louisville to help.
Don't be shy about getting your kid to the doctor if they've suffered a few headaches and nausea over the couple of weeks, right?
Exactly.
Okay, good deal. All right. Good talking to you, Dr. Michael Sowell. Appreciate you being on the show. Rodger Payne is a UofL political science professor who was a visiting scholar and a prestigious Fulbright scholar to Scotland and Canada, respectively. And he's also working on a series about President Trump's America First policy, and he's here to talk about that. Rodger, good to see you.
Hi. Well, I'm glad to be here.
Yeah, I'm glad you're here, too. All right, so you went to Canada and Scotland,
I
right,
did.
over the last couple of years, right?
The last year.
Last year?
A year ago this
Been a
time,
busy guy.
I was in Ottawa, Canada.
Ottawa, Canada. All right, and what'd you do in Scotland?
So I was there for about a month earlier this year. I was on sabbatical for a year in addition to my Fulbright. So I spent a month at University of Dundee in Scotland. It's maybe an hour by train outside of Edinburgh, on the coast near the North Sea.
Oh, wow.
And,
Sounds pretty.
I was working on a joint project there with another scholar. He's a human rights specialist, and I've been working on America First, so we're looking at the consequences of America First on global human rights norms.
Right. All right. So you spent a lot of time in Canada. How long did you spend in Canada?
About 4 months.
4 months there. And how long did you spend in Scotland?
About a little over a month.
Okay,
about 5 weeks,
so
maybe.
5 months in the last year or so you spent
Abroad.
in different countries.
Right.
All right. So, and you're working on this whole America First policy that President Trump has pretty much enacted in his image. So, what is America First, and what does it mean to folks not just in America, but folks around the world?
Sure. Well, I've been working on it primarily as an instrument of U.S. foreign policy and the reactions primarily of American allies. So America First might mean different things in a domestic context, and I'm not really addressing those very much, although the Human Rights Project may be spilling over to that. But a lot of it is about trade, right? The president, when he was campaigning, claimed that U.S. was treated unfairly in many different trade agreements, many bilateral trade deals, et cetera.
And he killed a couple of them.
He has threatened to kill some. He pulled the U.S. out of a process that that others continued, like Canada, for example, the Trans-Pacific Partnership. But some of it's about U.S. military commitments, both the use of force potentially and also alliance relationships, where he thought allies in particular were taking advantage of the U.S. The U.S. was paying for the military, and they were getting off relatively scot-free. No pun intended there. And then, even in a broader sense, a host of multilateral agreements that he has either withdrawn the U.S. from, like the Paris Climate Accord, or has threatened to withdraw from.
All right.
So it's a wide array.
So it's a wide array of things that fall under the umbrella of America First and Trump foreign policy. So what do folks in Scotland and Canada and elsewhere think, and our other allies, what do they think about this policy?
So they're not super enthused about it. So when I was in Canada, a lot of the focus was on NAFTA, the North American Free Trade Agreement, and during the terms of a negotiation, and the deal has been renegotiated, all three legislatures received it. Only Mexico so far has ratified it. So neither the U.S. nor Canada has ratified it. In Canada, it's really just a formality. They're basically waiting for the U.S. because for them, NAFTA is marginally better than the new U.S. Mexico-Canada agreement. The president calls it USMCA rather than NAFTA. It's a rebranding. But so until the U.S. renegotiates, or not, sorry, until it ratifies the new deal, they're fine with the old deal, right?
Right. But in a broader sense, when you're talking to the folks up in Canada, you're in Ottawa. What are they saying about this?
So it was a bargaining relationship. So for them, it was like, what are the terms going to be, right? So that part was okay. A lot of what they were upset about in Canada really was the things that President Trump was saying about Canada to kind of make the deal better.
He's making fun of Trudeau.
He was making fun of Trudeau.
Who just got reelected.
He called him dishonest and weak. He insulted the foreign minister, Chrystia Freeland.
But that's just Donald Trump. That's just the way he is,
right.
and we understand that. But when you go to what he's actually doing and what his policies are, have they actually taken a deep look at what he's actually done and doing and promising to do?
Well, obviously that's part of the agreement.
Right.
The details of the agreement, had to do partly with dairy, although that's a really microscopic part of U.S.-Canadian trade. But the president emphasized it often in his Twitter feed. Dairy costs more in Canada. It's just we subsidize farmers. They limit the number of number of farmers who can have access to the market, so their prices are higher. So it's just a different way of subsidizing farmers.
Right.
But a lot of concern about automobiles during the manufacture. A lot go back and forth across the borders. And, if NAFTA ended, it would be disastrous for both sides. Some of the president's own advisors basically said that the threat the president kept holding out of ending NAFTA might not have been very credible because it would send the stock market diving, according to one of his own advisors who was part of the negotiating team. Right. So that part is. But so the insults and the untruths, that was in some ways worse. In the UK, they've been very focused on Brexit, so they haven't been quite as worried about America First. A lot of the scholars that I met and talked to were, and some of the government officials I'm sure are. There were some insults that Trump levied at the UK sort of indirectly. Basically, when he visited, he would interfere in their domestic politics, right? Like he would come down in favor of some politicians over others and encourage them to get out of Brexit. And yeah, exactly. And Nigel Farage too, who heads the Brexit party, and they won a bunch of seats in the EU EU Parliament.
Right.
So,
Okay.
you know.
Yeah. We're talking with Rodger Payne, who is a political science professor here at the University of Louisville. He was a visiting scholar and a prestigious Fulbright scholar, visiting scholar to Scotland, Fulbright scholar to Canada, and spent some time in those countries, and is now looking at the America First policy that President Trump is putting into play. So, both Great Britain, the UK, and Canada value these multilateral agreements with Mexico.
And they're not alone.
They're not alone. I mean,
Yeah.
most of the world, I think, does, although that's changing in Europe and other places. So when you're talking about this America First policy that we have, does it threaten our agreements and our good feelings and everything with Canada and Great Britain, or are our feelings just hurt? We're upset because President Trump said some bad things about us.
The one thing that the president did that made Canada most annoyed, that potentially would have the long run relationship issue, is that in order to impose tariffs on Canada and a number of other countries as well, including Germany, the president doesn't have the authority. If you look at the U.S. Constitution, the Congress regulates commerce. So the Congress had passed a law long ago. Cold War context had been used primarily in very isolated cases against nasty regimes, which was they could label the other country a national security threat, and the president could limit exports or put sanctions on or something like that. So in order to put sanctions on Germany and Canada and some other U.S. allies, the Trump administration labeled basically imports of aluminum and steel from those countries as national security threats to the United States, which in their view, they were being labeled as, the whole country was being branded that, not just these particular exports. Mm-hmm. And also he was threatening to do the same thing with additional, like automobile trade, which would have been even a bigger segment. So that particular point, I think, is the rub. And there's some literature in my field about what are called security communities. It's a set of states, it's beyond alliances. It's countries that have the same form of government. They make promises to each other. They cooperate economically. The European Union is often considered a security community, and there's a Western security community that includes the United States and Australia, arguably Japan. Right. So it's not all geographic. And so security communities think that they don't pose threats to one another. So if you're labeling them threats to one another, that undermines the whole ideal.
Which President Trump has done from time to time.
Exactly.
All right, last question. You were in Scotland.
Yes.
Most of the Scottish people don't agree with Brexit.
Right.
Why? And why don't they agree with Trump and Boris Johnson that England needs to get out of this?
So the people I was meeting in particular, I spent a lot of time in Dundee, a university town, and in Edinburgh. Those are very cosmopolitan areas of the UK. If you look at the map of where Brexit succeeded, it wasn't London. In Edinburgh,
it was the rural areas.
In Edinburgh, 3/4 of the people voted to remain.
Much like the reason Donald Trump got elected in America.
Right. So, Scotland has plenty of rural area, but they also are heavily dependent upon tourism. The North Sea oil makes them very export dependent. They are very integrated in the EU. For some, they saw it as if the referendums had gone the other way, if the Brexit referendum had been first and then the Scottish independence referendum had been the other way, then Scotland likely would have voted for independence. Mm-hmm. So they would like to be an independent member of the EU as opposed to a member of the UK that's not in the EU. That would be their rank order preference.
Yes or no? Does our relationship with Canada improve or get worse now that Trudeau is reelected?
I think it doesn't change much. It could go down slightly because he'll be pulled to the left. He's going to make coalition partners on the left of him.
Okay, so it could get worse. Okay.
Could get worse.
Well, that's exciting. All right, Rodger Payne, always good to see you. Always good to talk to you, and welcome home. Hope you stay for a little while. What should you do if your child has a weird tic or they get tremors from time to time? Well, Dr. Chris Barton is a child neurologist at UofL, and he has some answers about pediatric movement disorders. Dr. Barton, good to see you.
Yeah, very nice being here.
I'm glad you're here. All right, what are pediatric movement disorders? How do you describe those?
So if you've ever interacted with a kid, have kids, kids do weird things all the time, constantly. And so it's hard to figure out as a parent, when is that something that I need to act on, or when do I need to see somebody more frequent? So let's kind of talk about this definition because it's really confusing. What actually makes it just a kid doing weird things versus a movement disorder? So movement disorders, we can say abnormal movements that happen that kids can't control that impact their quality of life. Sometimes they can be normal movements that you do at abnormal times. And sometimes they can be where the movements you try to do aren't correct. And so we really try to look at, hey, is this causing issues? Is it causing problems? And then paring that down to what the specific issue is.
All right. And so how do you figure that out? How do you know if it's a movement disorder or just, like you said, something weird that your kid's doing?
For sure. So in 2019, in medicine, we really rely a lot more on blood tests, on imaging, and with movement disorders, you have to rely on old school medicine in terms of taking a very good history and then really doing a very good exam in terms of trying to figure out which movement you're dealing with. So we spend a lot of time talking with kids in terms of when does this happen? Can you control it? Some different types of movements, you can sometimes feel the need to do it, or you can control it. Sometimes you can't. And then depending on other things kids have going on, sometimes that can be helpful too.
Okay. Well, what are some of the things that we're talking about? Is it Tourette's? Is it? I can describe it as a tic.
Yeah.
What are we talking about? Things that are movement disorders in kids?
So in adults, when we talk about movement disorders, tremor and Parkinson's are two things we think about. In kids, the most common by far is tics. So 40% of movement disorders in kids is tics. And so what a tic is sometimes an abnormal urge or need to act on either a movement or a voice. It can be confusing because you can somewhat control it, but you can't. Tics for kids, I often tell parents if they don't have tics themselves that it's like an itch that needs to be scratched. So you can not itch it, right? But then it feels painful and you don't like it, and so we all itch it anyway. And that's often what our kids experience with tics.
But when you're talking about tics, like you're blinking excessively, or you got your head swivels a few times, jerks a few times, that kind of stuff?
Absolutely. So we divide that into kind of motor versus vocal tics. So motor tics can be anything, honestly, but the most common I see are things like eye rolling, rapid blinking, sometimes twitching of the nose, twitching of the face, twitching of the extremities, and then vocal tics. And so we think about things such as abnormal grunts, sniffs, and then of course when people think about Tourette syndrome, they think about something called coprolalia, which is when kids may cuss uncontrollably. But that's actually incredibly rare. Only 3 to 5% of kids will have that.
Okay. So when parents see these tics going on in their kids, should they freak out?
And not at all. So most of the times, tics, for instance, can be something that goes away, especially in adulthood. But the reason it's important is because we know tics can go along with other things such as ADHD, OCD, anxiety. Oftentimes I say tics don't bother kids, but they bother teachers and parents. And so a lot of it is kind of trying to address these other things that can really hinder kids in terms of their learning and their development.
Right.
Other things we'll see, so tremor is probably the next most common thing we'll see in kids. In adults, essential tremor is very common. We'll actually see essential tremor present in kids as well. But we're always looking to make sure, just like in things like headaches, parents are always wanting to make sure that the brain's okay, that there's not a brain tumor. And so it's really important to be able to see these kids, especially as a tremor gets worse, and make sure there's not something else going on.
Right. We're talking with Dr. Chris Barton, who's a child neurologist at the University of Louisville. We're talking about pediatric movement disorders. And so what should parents do? I mean, if they start seeing their kids have these episodes, what should they do?
Yeah, so I like to say we can cheat now, which is great because every parent has the best doctor tool in the world on them 24/7, and that's a cell phone with video. And so if your kid does weird things, if I could create a public service announcement, take video of it. It's incredibly helpful for your doctor. It's incredibly helpful for us, especially movements when they're doing the thing. Other things can cause weird movements that aren't movement disorders, so thinking about things like seizures, for instance, are something we're always trying to rule out. And then there's also a class of what we call benign paroxysmal movements in childhood. So that means benign, normal movements that lots of kids do, but they don't cause problems, but they are scary for parents.
Right.
And sometimes we can be really helpful of just saying, hey, this is normal. This is something that we don't need to worry about, or this is something we do need to do further testing and work up.
Right. So get the kid to the doctor is the first thing to see what's going
With
on.
video.
With video would be awesome.
Yeah.
And the second part, though, is don't freak out. This is not a sign that your kid's got some major neurological problem. correct?
For the most part.
For the most part.
Yeah.
But that's why you go to the doctor to figure that out, right?
Yeah, absolutely. 100%.
Okay. All right. I want to move on to something else. Again, we're talking to Dr. Chris Barton, who's a child neurologist at the University of Louisville. Cerebral palsy. What is it? How do you describe it?
Yeah. So, so talking about movement disorders, it's not a true movement disorder in the classical sense, but it causes problems with movements in kids. So this is something that I take care of, and many of my partners take care of as well. And so cerebral palsy describes some injury to the developing brain, typically within the first 2 years of life. So oftentimes we'll think of, especially kids when they're born, that maybe they've had a rough pregnancy or a rough delivery where the brain gets stunned and has some kind of injury that causes lifelong problems. But it can be an infection that happens early in life. It can be something like a stroke. There are lots of different causes, but it tends to be something in the early developing brain.
Is it common?
It's very common. So we'll see anywhere from 1.5 to 4 in 1,000 births can result in cerebral palsy. And the cerebral palsy the name implies problems with movement. So when people think of cerebral palsy, they think of kids that have trouble either moving their legs, moving their arms, moving one side of the body. But the other stuff that can come up can have problems with learning, with developing, can have other things that go along with that, such as seizures, can cause problems with behavior. And so we actually work in a big interdisciplinary team and have multiple cerebral palsy clinics that involve neurologists, which one of our primary jobs is taking care of things like the behavior, the seizures, and also what caused the cerebral palsy. But then we have our really good friends in physical therapy, occupational therapy, orthopedics, physical medicine and rehabilitation, all working together as a team, taking care of these patients.
And I assume when a child has cerebral palsy that there is a spectrum of how severe it is. Is that a fair assessment?
That's 100%. So
Okay.
you may have a kid who has cerebral palsy, but really it just affects maybe their ankles a little bit, and they can walk normally, don't need any extra help, and they do well in school and have no seizures and go on to become doctors and physicians. And then you've got other kids, which is what most people think of on the radio, of cerebral palsy, kids that are wheelchair bound, who have lots of seizures, who have lots of needs and problems.
And what percentage of the kids have that severe, of the percentage of kids who have cerebral palsy, how many are in that severe category?
I'd say probably 1 in 5, 1 in 10 kids with cerebral palsy are much more severe.
But if they have like you said, if they have a light case, a less severe case, they go to school and everything's normal, and they just got to watch out for a seizure from time to time. Is that a fair?
Absolutely. And sometimes they're kids that we don't actually even know or recognize until later in life, because kids are always learning more things, developing more things, and so we may not pick up on those small little issues until they start running or playing sports or doing things.
And the treatment for this is to go to the doctor at the University of Louisville, and they'll get in a multidisciplinary program with a bunch of folks that you just mentioned.
Absolutely.
With them.
Dealing with things like the therapy is always the first thing. Oftentimes kids don't need medicine, but working on stretching, working on physical therapy, growing those things, and then we can talk about medicines to help with the stiffness. We can talk about different casting therapies that we can do, and then even more invasive things like Botox therapies or surgeries to help loosen those muscles.
All right. So parents, if you're out there listening, Dr. Chris Barton, Barton, just look on the University of Louisville webpage, and you can probably find his name and track him down if you think your kid has got some tics, perhaps cerebral palsy, whatever, right? Okay.
Yeah, me and my partner, Dr. Anna Ehret's been running our Tourette's clinic for a long time and does an excellent job, and we're both happy to see your kids.
Okay, very good. Chris, appreciate you being on the show.
Yeah.
All right, that'll about do it for this edition of UofL Today with Mark Hebert, which you can hear every Monday night at 7 and Sunday morning at 8 on Cards Radio 790 WKRD. You can also listen to the podcast of the shows on SoundCloud or watch the programs on Metro TV or KETKY throughout the week, or on UofL's YouTube channel anytime. Check out all the UofL news, videos, and events at UofLnews.com. Thanks for listening to UofL Today with Mark Hebert, and go Cards.